Ladies, hold on to your hats because we have some super exciting news. Today, we are kicking off a brand new initiative here at This is Perimenopause called Reclaim Your Rest with Endy.
So many women struggle with sleep issues and disturbances during perimenopause, and it's often one of the first symptoms. But it's so insidious that we don't even recognize what's going on, and neither do most of our medical providers.
Which is why we're tackling these issues head on and giving our listeners the information they need to reclaim their rest. And who better to partner with than Endy, Canada's leading online mattress?
Our Reclaim Your Rest with Endy series will feature a variety of experts on topics like how sleep impacts your health span, the connection between sleep and muscle recovery, and tools like CBTI. You're not going to want to miss a single episode.
And while you're listening, make sure you stay tuned until the end of each episode because we've got a big giveaway coming as part of this series. And I don't want to spoil the surprise, but it is going to be awesome.
We're kicking things off with one of our favorite guests, Dr. Jennifer Zelovitzky, the Clinical Director of Women's Health and Vitality at Medcan. For our listeners who don't know Dr. Jen or her Medcan program, it's an incredible 6-month evidence-based program dedicated to personalized care for menopause and perimenopause to help women feel their best.
Today, we're talking with Dr. Jen about identifying the root causes of your sleep issues to help you reclaim your rest.
Because if you're not sleeping, nothing else is working. This is Perimenopause.
And before we get into today's episode, here's a quick word from our new sponsor.
This episode is brought to you by Endy, Canada's leading online mattress brand trusted by over 1 million sleepers. Let's talk about sleep, because there's nothing more essential than a good mattress to wake up feeling your best. Endy's mattresses are designed to keep you cool and supported all night long, so you wake up feeling refreshed and ready to take on your day. With 3 comfort options, plush, medium firm, and firm, you can find the perfect fit for your body and sleep style. And the best part? Endy delivers straight to your door, so upgrading your sleep is simpler than ever. Check them out at endy.com. That's ENDY.com.
Dr. Jen, we are huge fans of you and your approach with perimenopause care, as you know. So today we want to talk to you a little bit about sleep. And I think that every woman going through perimenopause can attest to the fact that their sleep has changed in some way or form. And so when people come into your clinic and they're suffering maybe from some symptoms, is sleep one of the first things you tackle?
Yes. And I think this has been an evolution for me as I've spoken to more women and as I've learned and heard their stories and really worked through symptoms with them, is that I will now start by saying, tell me what a typical night looks like for you.
Oh, serious? Okay.
Yes. Sleep is now becoming more widely accepted in the menopause community as really the tip of the iceberg when it comes to the menopause transition. Sleep sometimes goes off the rails even before your periods start to change.
Yeah, for sure.
Right? It can be the very first or the cardinal symptom, and we can't ignore it because so much of the other things that come up with menopause and the menopause transition flow from the tip of that iceberg, right? So if we don't get your sleep right, nothing else is really going to be falling into place. And that makes it sound simple, but it's not a simple problem to solve.
No, for sure. We were just talking yesterday with our last week with a personal trainer, and he was saying we were talking about physical and nutrition, but sleep was still one of the penultimate things that we need to have under control in order for the rest of everything else to kind of flow properly.
For sure. And also, I mean, there's been a lot of talk and a lot of controversy about perimenopause and the risk of cardiovascular disease and dementia, and, some implication that maybe hormone therapy can prevent those things. And the truth is, there's some evidence out there that hormone therapy in and of itself can help prevent, bad health outcomes, but really it's more the sleep aspect. So if hormone therapy happens to be what cures your sleep disturbances, whatever it is that cures your sleep disturbances, women who sleep better stay healthier later in life. And so I think it's really that connection there. So for some women, it might be the hormone therapy, but whatever it is, and we're going to talk about a whole bunch of different possibilities, whatever it is that remedies your sleep is then going to unlock that future of good health for you.
Mm. So maybe can we get into some different approaches? You know, what medications, work with what issues? I mean, is that a thing? Like certain, depending on what the sleep issue is, will determine where you start in terms of medication or approaches?
Right. So first, I will usually tease out, are you having trouble falling asleep or staying asleep or both?
Mm.
Mm.
Are you waking up multiple times during the night? And if so, why? Sometimes they can tell me exactly why they're waking up, right? Like, I'm sweating, I'm soaking the bed, I have to change my pajamas, I have to throw the covers off. Okay. Sometimes it's I'm snoring or I wake up feeling like I stopped breathing. Okay,
Mm.
well, that might be something entirely different. Or I really can't fall asleep. My brain just goes and goes. I worry about crazy things. I have a great example of this from myself the other night. I lay in bed worrying in the middle of the night about whether I should be taking my own garment bags to the dry cleaner so I didn't have to get plastic bags around my clothes. I think I can worry about this sometime other than 3 a.m. But
How long did you stay up doing that, ruminating that?
look, I do this for a living, so it was brief. I was like, we can do this. We can do this tomorrow. This isn't a 3 a.m. problem, but or sometimes it's your dog will. I have 3 dogs. Like sometimes my dogs just wake me up, and there's nothing really I can do much about that except try to control my environment. Restless legs, that's another great one. Well, my legs won't
Mm-hmm.
stop kicking, and I'm having trouble. Sometimes it's major stressors. So we try to tease it out, but often by finding out is it falling asleep or staying asleep, we can kind of get started down one road or the other, because a true menopause transition sleep disturbance is typically a story like, I have no trouble falling asleep. I can't wait to get into bed and fall asleep. But then I wake up over and over, or I wake up at 2 a.m. and there's nothing I can do. I'm always waking up at 2 a.m. and then I'm
Ding,
up for
ding, ding,
hours,
ding.
right?
Yeah. Yeah.
So that's a more classic situation where it's perimenopause. But of course, there are non perimenopause related reasons a woman can be having sleep disturbances. And we really want to get to the root of it, because you don't want to assume, right? Just because a woman is in her 40s and she's having irregular periods or whatever, you don't want to assume that's the only thing going on, or there's nothing else that could potentially be impacting her ability to sleep. So it's really important to tease all of that out.
So, 2 a.m. wake up, that was me,
Yeah.
losing my freaking mind because I also was, I had a bout of insomnia in my 20s and I went to sleep school in my 20s. So I was ahead of the curve on the sleep hygiene thing. I can actually be in the bedroom sleeping with my phone and I can pick it up to turn off an alarm or whatever and not actually look at the time. Like I'm very well trained. All that to say, 2 a.m. would roll around in my early 40s and I was awake and like not just awake, like plugged into an electrical socket awake. So, what do you do for that? What is your, when it's not, when you've teased out all the other things, you're like, okay, no, this is a classic. Your hormones are wreaking havoc. What do you do?
So a patient coined that for me as tired wired. She's
Yeah.
had no other way to
Mm.
describe it. It's just, I'm tired wired. I'm exhausted, but my brain won't let me sleep.
Yeah.
So then I always think about the various different things that could be going on and probably are going in that woman's mind. So you very wisely said, I know the difference between insomnia, which is typically more characterized by having trouble falling asleep or waking up early and just completely up for the rest of the night. And that can be remedied by a combination of things like sleep hygiene, CBT for insomnia, which is a multifaceted approach, sleep restriction, those types of things. And there is a small subset of women in perimenopause who truly have primary insomnia, but more often it's the other thing. It's the I wake up at 2 a.m. So I really get into whether they're actually having vasomotor symptoms. And women are great at underplaying this or comparing it or thinking. I had someone yesterday, it was such a great story. She ranked her night sweats as mild. And then when we really talked about it, it was the typical story of, well, yeah, I'm not like soaking the bed. My husband sleeps in a separate room now, and I've stopped wearing pajamas, and the fan has to be on at all times, right? And I'll throw my blankets off, but I don't have night sweats. And I said, okay, I'm going to respectfully upgrade your vasomotor symptoms to moderate severe, if you're okay with that. I mean, the truth is, it doesn't really matter because there's an amazing study, a graph I love to show at all my talks. It shows the impact on sleep and daytime productivity of hot flashes or vasomotor symptoms, regardless of whether they're mild, moderate, or severe. So even though the guidelines say, oh, only moderate or severe should get hormone therapy, mild hot flashes at night, mild temperature dysregulation at night has the same impact on daytime productivity and sleep disturbance as severe ones. And in fact, there are studies that show that women who weren't even aware of their vasomotor symptoms, so there were objective monitors they wore that showed if they had a hot flash at night, they didn't even have to be aware of it, but they would still be having WASO, which is wakefulness after sleep onset, which is like the fancy, it sounds like a jujitsu term, but it's like it's a term for those waking up for no reason. So that's one. We have to make sure.
But sorry, and I would tell you that I've never had a night sweat or whatever, but what you just described, I'm like, no, I kick off. I now sleep in boxer shorts and a tank top and leg warmers because I get jumpy legs, and then I kick all the blankets. But I would tell you, I've never had an, Oh, interesting.
So sometimes now I'm trying to like correct the terminology and be like temperature dysregulation. Because if you say to a woman, do you have temperature dysregulation? Oh, yeah. Right. So I almost think it's time for a little bit of a change in the terminology. But the other things the other chemicals that are impacting our sleep at night, other than the hormones, is orexin. So we have this chemical called orexin, which is our wakefulness. It's a wakefulness neurotransmitter, and it is suppressed by estrogen. So I always think of estrogen as like the teacher on the schoolyard, and she's keeping these kids from like bouncing around and jumping on everything. And when the teacher leaves, it's like, woohoo, we're going to go crazy now. So the orexin, there's more orexin, and then there's orexin receptors in the hypothalamus, and they have an interplay also with temperature, but predominantly it's wakefulness. So it's like it's flooding these receptors. And so there are medications now, fortunately, that we can talk about that specifically target that, but it can be just pure wakefulness. That the normal channels, the things that are supposed to be suppressed at night, are no longer suppressed. And so it's all bets are off and you're awake. Serotonin's also a chemical in the brain that can influence our sleep patterns. And this can come into play if perhaps you have mood symptoms of perimenopause or baseline mood symptoms. So women who have anxiety or depression are more likely to have sleep disturbances, and vice versa. If you're waking up all the time, it can have a negative impact on your mood and cause more anxiety. It's not acceptable for women to go years and years with sleep deprivation. I don't know any human being that could go months or years on end without sleeping well and not be depressed, anxious, irritable, and tired, frankly, just exhausted.
And yet that is so not, it's so normalized for people
Absolutely.
to be like, yeah, I don't sleep.
And some people wear it as a badge of honor. Oh, yeah. I haven't slept in years. I don't like, oh my God.
But we need more sleep when we reach midlife. I know how it felt. I used to be okay with 5 hours and I could function really, really well. Those days are over.
So there are a variety of medications and other tools like cognitive behavioral therapy for insomnia that you use, and you target that depending on what the specific issues are.
Exactly. So if the issue is predominantly or partly hormonal, of course, estrogen, if that's appropriate for you, can definitely help settle settle your brain down through multiple channels, but mainly by just turning those hot flashes, dialing the temperature dysregulation down. Progesterone, which is often paired with estrogen, also has unique properties in that it does protect the uterus against, irregular bleeding and hypertrophy. But in the brain, it acts on the GABA receptors, which are the relaxation, feel good, anti-anxiety receptors. So it does help a lot of women sleep. There was actually a lot of controversy about this at the recent Menopause Society conference because one of the presenters said, look, the studies do not show that progesterone actually has a positive impact on sleep. And everyone there was like, but it does.
Was this a male presenting, or?
He's a really good doctor. He's really an expert. No, he's an expert. But
No, fair.
I don't know why for some reason the studies show mixed results when we actually treat women. And yes, it is not always the answer, but for a great number of women, the progesterone really does help them with their sleep. And it doesn't always work. And that's where maybe other factors are at play, like the orexin receptors, right? And now we have wonderful medications called DORAs, or dual orexin receptor antagonists. What these do is they create a little bit of a blockade at those orexin receptors so that the orexin can't attach to the receptor and wake you up and stimulate your wakefulness. They're very different than traditional sleeping pills, which we can also talk about the potential harms of those. But they're very different in the sense that they are not habit forming. And this is wonderful. And it's what I love to reassure women about. I have a patient from years back who, she got the Sunday night scaries. So every Sunday night she would take a Dora, and she was doing that for a really long time. She didn't have to take it any more or any less. She just said, it's perfect. The one night a week that I know I'm not going to sleep, I take it. And so it was sort of like proof positive for me that this is something that you can take as needed, whether that's every night for a little while or sporadically, maybe when you have a busy day at work, you have trouble sleeping the night before, but they're specifically targeting the problem. So it's not like a Band-Aid solution. It's like, we know what the issue is. We know the chemical we're trying to target. Let's target that specifically.
And is Adora the actual drug, or is that the brand?
No, there are two types in Canada that I'm aware of. Lemborexant, which is the trade name Dayvigo, and Daridorexant, which is Quivavik, the weirdest name ever, but it's good. It's a good medication. I just hate saying it. It sounds weird.
Do I go to my family physician? Like, if I'm getting HT through my OBGYN, do I go to my family physician for this, or?
Your family physician should be familiar with these medications. They have been around for almost a decade.
Will I feel groggy in the morning?
So the rule of thumb is typically that you want to make sure, first of all, that there are no contraindications, and there's only 1 or 2 contraindications for this medication. You want to make sure you can get in about 7 hours of sleep. It's not good for like a shift work where you're like, I got to catch a quick 4-hour nap. Then you would wake up feeling groggy. But if you can get 7 to 8 hours, which is what we want to be aiming for anyway, it can be a wonderful choice. It can be associated with vivid or disturbing dreams. So in some women, you might experience that, but there's 2 different ones you can try. So you can play around a little bit with dosing and the specific type. If the dreams are not disturbing, I would say take it as a good thing that you're actually achieving that REM sleep, right? So it's some of us, we haven't been dreaming for years. We're not achieving deep enough sleep. So suddenly it's like, oh my goodness, I had this whole crazy dream. And it's like, that's kind of sometimes okay to have a crazy dream.
I have one last dumb question. Is this something that my husband can take too, or is this female only?
Yeah.
Oh, okay. We
as
both
long as
are like
he
not
clears
sleeping
it. I don't want to get, I could say yes or no. As long as he clears.
To be clear, Dr. Jen is not prescribing this to your husband.
No, but
over the internet.
Corner,
Yeah.
and I'll hand out prescriptions. No, it's for anybody who has trouble. It's one of the safest and most wonderful options for sleep that we've had in a really long time, because most of the other options are terrible.
Yeah.
I don't like prescribing them. And so then other than that, there can be mood related dysfunction in sleep. Depression can happen with or without perimenopause. And one of the main symptoms of depression is sleep disruption, early morning wakening, or with anxiety, trouble falling asleep. And in those cases, something like a serotonin, an SSRI or an SNRI might actually be part of or the whole solution. Sometimes in conjunction. I have patients who are on combinations of hormone therapy and a DORA, or an SSRI and a DORA, or all three. And we sort of just, we have to solve all of those problems to get you sleeping really well.
And this is why, PSA from us, you need more than a 10-minute appointment to sort through this stuff, right? It's complex. And there are solutions, but you've got to parse, to your point, Dr. Jen, you've got to parse it out.
You do. And that's why I love explaining to women all of these different facets of sleep, because you can go to your doctor and say, you know what? I'm thinking this might be my issue. I've ruled all of these other things out, and I'm really interested in this medication. And if your doctor says, I've never heard of that, say, well, can you go look into it and let me know if you think it's appropriate for me? You might be actually helping your doctor. You're putting a new tool in their toolbox that they didn't have before.
For sure. I think it's also, we're a little naive, especially in a country where we have had free healthcare for our entire lives. And we're now in a bit of a crunch where that just isn't working the way it once was. But we also have this naive assumption that we can just roll in and the doctor sitting across from us is magically going to read our minds and know everything about every ailment on the planet and be able, in that short period of time, which they are, that's how their world is structured. That's how they get paid, right? It's not them saying it can only be 10 minutes, right? That's how this is funded. To think that they're going to be able to figure this out is just, it's ridiculous, right? We need to help them.
Well, and they're missing the whole component of it. That's perimenopause for the most part. I mean, you're lucky if you have a doctor where that even goes through their mind that your sleep problems could be because of perimenopause, and have an understanding of the myriad ways that perimenopause affects the brain and the sleep center.
Yeah.
So that's a big ask.
I have one more question for you, Dr. Jen, in terms of things that contribute. So I finally started taking vaginal estrogen and their Vagifem, and I couldn't believe within a very short period of time, that's not always the case for everyone as I understand it, but in a very short period of time, I no longer had urgency. I no longer was leaking if I had a bad cough or I tried to get on a trampoline, which does not happen very often anymore.
Yes.
But,
Yes.
and I stopped having to wake up to pee.
Like ever? You never wake up to pee anymore?
Well, now it's like once in a while. It used to be 2 or 3 times a night. Now I'm like, oh yeah, I didn't get up last night. And like, is that also a thing?
Yes, we didn't even work our way down to that. But yes, of course. And that can be hard to tease out, because sometimes women are like, well, I wake up and I have to pee, but I don't know if I wake up because I have to pee or I have to pee because I woke up.
I, in a million years, would never have said I'm waking up because I have to pee. I was always like, oh, well, I'm up, I'm going to pee.
Yes. So my dog or my husband has woken me up because they had to pee. And so now I may as well go pee too.
Exactly. Saves me the trouble of next time I have to pee. That's a really good point. Vaginal, it's not just even like having to pee, but it can be vaginal irritation and itchiness. And that can disrupt your sleep. Pain can disrupt your sleep. Oh my gosh. I can give you all the hormones in the world, but if you have a frozen shoulder and if you've lived through that kind of pain, forget it. You're not sleeping. Right. And then life stressors. I wish hormones could fix a divorce or a job transition or, empty nest syndrome.
Yeah. Death.
Anxious child.
I wish. And unfortunately, we do go through little bumps in the road that, can't always be fixed. And we have to sort of then turn to a little bit of sleep hygiene, a little bit of therapy to work through those issues. But hopefully we come back around if it's not something such as a true depression, a true anxiety disorder, and it tends to be temporary and situational.
So Dr. Jen, what are some of your non-negotiables when it comes to sleep?
So for women in the menopause transition, 7 to 8 hours. If I'm giving you all the tools, but you're going to be doom scrolling or working on your job until
Which aren't those the same thing most of the time?
2, well,
I'm
yeah,
just kidding.
exactly. Well, it can be 2 a.m. and say, well, it doesn't matter. I'm just going to go to bed at 2 and wake up at 6. You're just going to be tired, and you're just not giving yourself the opportunity to get the sleep that you need to feel restored and to avoid brain fog and all of those things that happen when we're not sleeping well. So that's one non-negotiable. And solve it with the right solution that is, how am I going to put this? Identify the root of the problem and then solve the root of the problem. And the third is around substances.
Gotta plug my ears.
Sorry, I can't help you if you're going to go have an espresso at 10 p.m. or you're going to have 5 glasses of wine at 8 p.m. or you're going to eat dinner at 11 p.m. I can give you anything in the world, but I can't be there in your house to remind you not to do the things, or even the good things like exercise. Don't exercise an hour before bed, unless it's like restorative yoga and it's going to help you sleep. There are certain things you really have to do. I can't do them for you, but really when it comes to like sleep hygiene and do's and don'ts and no phone in the room and no TV in the room, I think if you're solving the problem and you're reasonable about your sleep hygiene, the rest you'll sleep no matter what, basically is what I'm saying. I don't think it's always realistic not to have your phone. It's my alarm clock. Like, what am I supposed to do?
I want to know if my son needs me in the middle of the night. Like,
that's the other thing. I have 2 girls in university. My ringer's on it now at night, and I'm like, I need to be reachable. Some people have a job where they're on call. Like, you don't always have the luxury of those things, but I'm here to tell you from my, firsthand experience, if you've got everything else together, that won't matter.
Can I ask you, so I've been on HT for a while. It did definitely help with my sleep disturbances. Now, for whatever reason, some of it is anxiety for sure. And just like son being at university and he's having some anxiety issues, and he's the only one in the world, though, of course, that's struggling with first year university. Because anyway, no, they're all going through it, but they're not talking to each other. Anyway, I digress. So I'm curious, anxiety aside, because the sleep issues have reared up before this, do I then consider tweaking my HT, or do I look at this other sleep pill that you talked about, which I've already forgotten the name of? I'll have to go back. Like, what?
Dual orexin receptor antagonist.
Yeah.
So,
Dharma.
I think it depends. If you felt a bump up in your temperature dysregulation?
Oh, well, a little, maybe.
Perhaps.
Yeah, maybe.
That might be why. You might want to look to good old relaxation therapies.
Mm-hmm.
Like
I do a lot of breath work in the middle of the
breath
night.
work, meditation. Those can be extremely helpful tools at bedtime. I know you guys know Alana McGinn. So do you know Alana?
I know the name, but I'm having trouble.
Oh, okay. So she's a sleep expert. I thought for some reason you guys knew her.
Dr. Jen. Is that why I know?
Well,
Gina is.
Yes, that's right.
Yes. Sorry, thank you.
She's on Gina Livy, and I had her on my podcast back in the day. She's a sleep expert, and she has a really good method, especially for women in this stage of life. And it's like the 1 hour before bed that you set aside and you divide it by 3. So you take your hour before bed, the first 20 minutes, you get ready for the next day. That means putting out your clothes. It means preparing your lunches, but it also means jotting down or putting in your phone a list of all the things you have on your mind that you could potentially worry about during the night. And you say, I've got this now. I've got this documented, so I won't forget anything. And then tomorrow I can look at this if I need to. But for tonight, I'm going to set this aside and
Oh,
put
I
it away.
like this.
The second 20 minutes are getting yourself ready for bed. So all of your rituals, whether it's a shower and then put on all your face creams and get yourself all ready. And the last 20 minutes is just for you. You can do whatever you want. You can read a book. You can meditate. You can stare at the ceiling. Whatever you want to do, but it creates this really nice separation between your day and your night. And I found it really, really effective for myself. So that might be very helpful for going through these
Yeah, I'm gonna try that.
situations where it's sort of like out of your control. You can't control your son's experience and his anxiety. I can tell you it's really, really normal.
Yeah.
Especially around midterms.
That's when it all erupted, right?
Every year they go through this. I mean, my daughter's in 4th year and she's still freaked out 2 weeks ago. So I can reassure you, as a mom of a 4th year and a 2nd year, you go this again.
Yeah. Okay. Great. I was hoping it was a one-off.
You know the other side of it. And then I even remind my daughters, I'm like, you know why this is happening, right? Because it happens every year. And then they're like, I know. I said, and every year you get through it. I know. So it can't make it better in the moment, but it can give you perspective that, we've been here before. They have the midterm freak out, and
I can still sleep through this. It's okay.
Totally.
Thank you.
I'm here to tell you they all survive it. Yeah, definitely. It's a quench. They're being stressed. They're being tested.
Intentionally, right? Like it's part of the yeah.
Mhm.
Yeah.
Part of the process.
Totally.
Thank you.
Are you a good sleeper?
I am now. I think
Oh.
I went through years, when my kids were little.
Mhm.
I slept with one eye open, and I didn't sleep very much, and I didn't sleep very well, and I think we all kind of go through that when our kids are little. I was always sort of like more anxious, wired that way. Now I'm a really good sleeper. I have to say we had a number of issues to get through to get there. Without like TMI, I'm just like you. I'm a woman who went through a terrible perimenopause. I had a very large fibroid. I had hideously heavy bleeding where my iron was in my boots, and I had leg aches and everything from my iron being so low. So I had surgery, I went on iron, I did all the things. Once that was corrected, I started to already feel my sleep improved. But then, of course, temperature dysregulation kicks in, went on some estrogen therapy, so that improved. And then I really started looking at committing to 7 to 8 hours of sleep. So my rule of thumb now is I aim for 8 hours, knowing the reality of the situation is the dog's going to wake me up at some point. Something's going to happen at some point that'll wake me up, but I'll go back to sleep, and there's some comfort in my brain of knowing I've given myself that cushion of the extra hour.
I like that.
Right.
So I typically will get
smart.
7 to 7.5 hours realistically.
Yep.
And I don't beat myself up if a bad night happens and I don't get that much. But I think exercise is the also really key thing I've started prioritizing.
Mm-hmm.
And shocking what a difference that makes in your sleep.
I need to go do that after this podcast. I didn't do it yet today.
Yes, it cannot be underestimated, the power of exercise on your sleep.
Yeah. And so for anybody listening who's just totally overwhelmed now, because it is a lot, right? And we the three of us on this call, different backgrounds, different people, but similar, like it's been a journey to get to a point. And Michelle, you were sleeping well and now you're not again, right? And I think the key is, take the time and find a practitioner who's going to take the time with you to sort out what it is, right? Like maybe you have an iron deficiency that is going unnoticed or unaddressed. Maybe you're really low in vitamin D. Maybe you're there's all of these different things. And I think the social media feeds can be dicey because you read about, oh, all I need to do is take more vitamin D and I'll be fine. Well, maybe, but
Mhm.
maybe not, right? You've got to figure out what's going on with you and then step by step start doing all of the things that are going to get you there.
And I think family doctors are obviously very, very busy and
Yeah.
stressed and overtaxed, but most are very reasonable. And I think if you come to them with information and a strategy, they'll actually appreciate it. Like,
Yeah.
I think coming to them and saying, I want to check my iron, they might be like, no. But if you say, I'm having really, really heavy periods, and I've noticed the heavier my periods are getting, the more
Mm.
trouble I'm having with my sleep. I've heard iron deficiency can cause sleep disturbances. I think we should check my ferritin to make sure it's not at a level where I should be concerned. That might come across very differently. I know it's a lot to ask. You don't sign up to be the doctor in your doctor patient relationship.
No, but you need to be your own advocate, right?
You really have to. Nobody else is going to, come in and rescue you. It's important to know that the vast, vast majority of women that I've seen have found relief from their sleep disturbances.
And I think that's why that's one of the reasons we'll take any excuse to talk to you because we love you.
I feel the same.
Thank you. That's a huge compliment. But again, just for people to hear this and realize, oh shit, this isn't just how it is. And I'm not just not sleeping because I'm getting old or older or because there are reasons it is happening and there are solutions. But it does take some time and some investigative work to figure out what's going on and what the right solution is for you in your unique scenario. And
Mhm.
I can say, so worth it. I was in complete misery and I now, for the most part, sleep through the night and I am like a different human being. Just ask Michelle.
Yeah.
Amazing. Oh my gosh, that's amazing. And
Although she's
we
been
didn't meet.
complaining about jet lag lately, so
Oh my
Oh
God. I
yeah.
was away and I was in Italy, which was amazing. And I got back a week ago tonight and it's kicking my butt.
I was yep, I experienced that a couple of years ago. It's terrible. It hits differently. So many things hit differently.
Yeah.
Yeah.
The
Yeah.
other thing too, I mean, we could do a whole other episode on the health benefits of sleep and the health detriment of not sleeping. So it really is something worth prioritizing. It has an impact on your weight. It has an impact on your cardiovascular health, on your cognitive health, your mood, and your
Mhm.
vulnerability to mood disorders. So we really need to start taking it more seriously.
It's like the one pillar. Like it's like for
Mhm.
me, it's like the one thing. Yeah.
Totally. Top of the
Yeah.
pyramid, top of the
Yeah.
iceberg. It really
Yeah.
is.
Yeah.
Yeah.
Love
Yeah.
it.
Um, we'll do our one last question maybe, and then we'll plan to do another episode on what you just said, because that's very important as well. What To cap off today, what's the one thing you want every woman to know about sleep and perimenopause?
So I want them to know that it is actually at the center of the hub or the Venn diagram. There's been an understanding and awakening in the menopause community that we actually have to look at sleep as the primary central dysfunction in the menopause transition, and that many other outcomes sort of arise from the lack of sleep, and many other symptoms arise from the lack of sleep. And so it's actually very, very important. If someone just says, are you having hot flashes? Are you having irregular periods? Then it's not perimenopause. Find another doctor, because they're just not aware, or they haven't talked to a lot of
Yeah.
women, because sleep is always, always checked off as one of the primary concerns when I meet with women. And it's not going to get better on its own in most cases. You do need to have a really targeted approach and an individualized approach. So don't give up on yourself.
Mhm.
Don't accept the status quo, and find an answer to your sleep disruptions.
Amazing.
Amazing. Thank you, Dr. Jen. So good.
Thanks so much for listening to the show. If you like what you hear, please subscribe and write a review.
So more women can find us and get a better understanding of what to expect in perimenopause.
This information is not intended as medical advice. The intent of this information is to provide the listener with knowledge to support more efficient and effective communication with their medical provider.